Welcome to the Air Medical Today podcast. My name is Edward Ero, and I am your host for episode 40 on July 2nd, 2021. This podcast is part of the Ero Podcast Network, podcasts that inform by focusing on both the news and the people behind the news. With each episode of Air Medical Today, we explore a specific area of the air medical industry and community through the use of interviews. You can find Air Medical Today on the web at airmedtoday.com and on Facebook, Twitter, LinkedIn, Pinterest, and Instagram. The audio podcast is indexed on iTunes, and the video portion is on YouTube. For additional information about the guests on the podcast, I also provide background data on the Air Medical Today website. If you would like to become a sponsor or leave feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. Today, I am interviewing Ms. Eileen Frazier, the Executive Director of the Commission on the Accreditation of Medical Transport Systems. Before we get to the interview, I want to go over some feedback from previous episodes and provide some general updates. As I have announced several times before now, Air Medical Today is also a video podcast. As always, you can listen to the podcast and now watch it on the new Air Medical Today YouTube channel. The link to the channel is on the Air Medical Today website. I mentioned during the last episode that Air Medical Today was back on Pinterest. Well, Pinterest is not allowing more than 5 posts per day for news and information. And this is not enough for us to provide the coverage that is needed for the air medical community and COVID-19. If they change this limit, we will start posting again. You can still follow news and information on Facebook, Twitter, LinkedIn, and Instagram. If you have not listened to past podcasts, please take the time to do so. There's a wealth of information from some of the key leaders in the air medical and EMS transport. Please tune in to these informative and timeless podcasts. I would also like to thank the followers of Air Medical Today on Facebook, Twitter, LinkedIn, Pinterest, and Instagram. To date, Air Medical Today has 29,638 likes or followers, and it is increasing every day. Thank you so much. It is my pleasure to welcome Eileen Frazier, the Executive Director of the Commission on the Accreditation of Medical Transport Systems, or CAMTS. Ms. Frazier has a wealth of experience in the air medical transport, including being the Chief Flight Nurse at University MedEvac at the Lehigh Valley Hospital in Allentown, Pennsylvania, and serving on a number of boards and committees. She has written several articles and is now writing a new book with the working title of Helicopters and Medicine. Eileen was the recipient of the Jim Charlson Award given to those that make significant contributions to the air medical safety, and in 1991, the Marriott Carlson Award given for outstanding contributions to the air medical transport community. That was done in 2000. Both of the awards are sponsored by the Association of Air Medical Services. Well, welcome to the podcast, Eileen. It's really great to have you on.
Well, good morning, and thank you for the invite. This will be very interesting. I've not done a podcast before.
Oh, is that right?
That's
I
right.
thought for sure with all your experience that you have, and it's been quite an ordeal to get this thing off the ground with the heat wave that you've been having out in the Northwest. You said it's a little cooler today?
Yeah, it's wonderful.
Yeah, that's nice. And I want to thank Rick, too, for because I know we had issues with trying to record at your house with the internet speed, and then your internet was down too for a while.
Oh, yes.
So we're actually at the Friday Harbor Airport in Friday Harbor, Washington, out in San Juan Islands. So we appreciate Rick setting you up there. So as I always do on the podcast, I like to provide our listeners with some information about your background and experience. And I've known you for years, and I did not realize all that you've done and accomplished over the years. It's just, that's why I love doing these, because I always learn so much about people. And you've done quite a bit. But let's start from when you started out as a staff nurse. I believe it was the emergency department at the Allentown Hospital, and later the Lehigh Valley Hospital after graduating from School of Nursing in '67. Has emergency medicine always been something that you aspired to?
Actually, when I graduated, I wanted to be on ICU rather than the ER. That was my second choice, but
Yeah.
there weren't any positions available. So I got the ER, and I was always so glad I did, because I love it. I still
Yeah.
love it. That's my most fond memories, actually.
Really? Yeah. So
Mhm.
what, and you worked at two different hospitals then, right?
Yeah, what they did was they took the city hospital, which is where I graduated from. And that was like my home, because I worked there from the time I was 16 as a junior nurse's aide,
Oh, okay.
and
So
got
you
a
had
full
some experience.
scholarship with the hospital program.
Wow.
And then they made a level 1 trauma center, and it's now sprawling, huge center for cardiac and trauma. And they did that in about 1971. That was built.
I see. So are you from that area?
Yes, born and
Yeah.
raised. Whole family has been there since the 1700s.
Oh my gosh.
Yeah.
From England or
My dad's side from England, my mom's side from Germany.
Germany? Yeah. Okay.
Mhm.
Sounds like my background. I don't know if you've done that, 23andMe and all those
We
things. And
did. Yeah. Yeah.
mine
It's
is
kind of, yeah.
English, German. I think I have some French in there too. So, and my family settled on the other side of Pennsylvania in Newcastle, which is north of Pittsburgh there.
Yeah. I don't
So,
think you come from Pennsylvania without having some sort of German, background there.
yeah, yeah.
Mhm.
So, in '81, you became the head nurse at the emergency department. And as you said, the trauma center starting. Had you always been attracted on going into a leadership role, or does that?
I was. I was taking courses at Cedar Crest College for my BSN, which then was pretty new. It
Yes,
was a new graduate degree. And so I was taking courses and just working part-time nights, because after 5 years, I finally had a baby and my daughter, and I didn't want to leave my daughter alone. So I worked part-time nights for a while.
I see. Um, the Then in '82, I think from reading, I just wanted to get it clear. Is that when Lehigh Valley started the flight program in
No, they
'82?
actually started it in 81.
'81. So you weren't involved right from the very beginning
I
then?
was. I
Oh,
was, because as the head nurse in the trauma center, I
oh,
was
okay.
real close with the trauma people, and we started training, and we did ATLS courses, we did intubations in the OR, we did all the medical training necessary. We just forgot about working around an aircraft and didn't have that training.
Yeah. So you were involved and then became the chief flight nurse then of the program.
Yes, the nurse that had a teaching degree was actually helping with all the training. And she said to me one day, well, I'm not going to be in a helicopter. I don't like it. Why don't we switch roles, and I'll be the head nurse in the ER and you be the
Oh, okay.
flight nurse.
So that's why the
And
dates were a
can
little,
you
yeah.
imagine even that happening today?
Yeah.
So we went to the head of nursing, and she said, oh, okay. Yeah, just switch. So I became a chief flight nurse, which had no job description, nothing. I just started from there.
Yeah. And that was one of the early programs too, right? I mean,
Yeah, I think we were the 13th in the country.
yeah, in the early
Mhm.
'80s. So that's great. And you served in that role until 1990.
Right.
And so I've already learned two other things. So emergency medicine was your second choice, and then you flipped jobs to get the chief flight nurse, and that has defined your career. That's wonderful.
It's crazy.
So, yeah. Uh, So tell us about some things with the startup of the program and through 1990. What are the types of things you were dealing with?
Well, as I said, we were well prepared. If you read the part about my first flight, I've written this and published it a couple different places, just to get the point across to nurses today that what we missed was any kind of training around aviation. My first flight was at midnight, and they announced that day they were going to start helicopter transport. And we got a call, and it was a trauma patient in a hospital about 60 miles away. And we were waiting for the helicopter to land because it was coming up from Westchester, Philadelphia. We still didn't have a contract with the helicopter service. And it was Keystone Helicopters.
Yes, I was going to say, yeah.
Mm-hmm. And so when we got, I was a little nervous, and I said to the resident, I don't think I've ever been near a helicopter. Oh, he said, don't worry about it. I was in Vietnam. I know all about it. Well, he didn't know about this particular helicopter. It was a BO-105. And so the pilot landed, got out, and helped us get in, showed us where to sit, so showed us how to fasten seatbelts, showed us how to talk on the headsets, which, of course, I didn't have any of that knowledge. And on the way, I noticed that the lights in the cockpit went out, and he had a flashlight in his mouth, and that's how he was seeing what the cockpit was telling him.
Oh, no.
And I thought, what? That doesn't seem right. I don't know. And when we got to the hospital, there were no lights, and we had to call back and tell them to turn the lights on. What we didn't know is the parking lot lights were turned off at midnight to save on electric. So they had to quick turn those on. We circled. Then we landed. We got out. We had the stretcher, took it in. It was a really severely injured trauma patient. Fractures, needed chest tubes, needed intubation. We got him all ready to go and got him on the stretcher. And we get out to the helicopter, and we had him on the wrong way. As you know, in a BO-105, you can only put the patient in head first, and on the stretcher that way. We had to take him out and change him around. And I was glad he was unconscious, because then I wouldn't have been so embarrassed for him or worry about him. So we got back to the trauma center, and the helipad faced like 7 stories of windows, and all the hospital people were standing there clapping. They're so excited. And Dr. Rhodes came out, and he's smiling, and he never smiles. And he looked at me and he said, well, what's wrong with you? And I said, we're not doing this anymore. Not another flight until we get everybody in here and gets oriented to how to work around a helicopter, period. We're not doing it. So the next morning he got the helicopter, and I got the nurses in, and we started learning how to work around a helicopter.
That's amazing. And especially given your background with standards and training and so forth, to have that experience. But I'm sure that's led you to what you've done.
It absolutely did. And even the next year we had a fatal accident, and I lost a classmate of mine, and Rick lost his best friend, who was the pilot that he had taught to fly, and the patient and the paramedic. And it was just a terrible, devastating thing. And I've always, since then, I know how crews feel about these things.
What year was that?
That was another lesson. That was April 27th, 1982.
Yeah, you remember exactly. Yeah,
I do. Yeah.
Having been through a crash myself at Duke.
Yes.
You remember the exact time. In fact, on my wall, I still have the picture hanging from that. So was the program always with Keystone then?
Yes, we were. Yeah. While I was there. It's changed since then, but while I was there, it was Keystone.
And the program's still going right now?
Oh, yeah. It is. They have ground transport now, too.
Excellent. So you got involved early on with ASH beams, too. And what is it? The Association for Hospital-Based Emergency Air Medical Services, right?
Got it.
and which is now called AIMS, or the Association
Right.
of Aeromedical Services. But on the safety committee, what caused your interest in safety, and what types of things did your committee work on when you were there?
Really, the accident is what did it. When I called around and tried to find out what kind of training, what kind of policies do you have, I was very much policy driven as an ER head nurse,
Yes.
and working with the Joint Commission. And I couldn't find anything. So we started writing some safety guidelines for AIMS. At the same time, HAI was working on some safety guidelines too. And we did several studies, and they're published in the Aeromedical Journal, as to, what kind of training are you giving your crews and that sort of thing. And Jim Smith in 1986, and in the meantime, I didn't tell you this, Rick and I, and Rick's always been my partner. Rick and I went to DC like every quarter at least, and we would meet with Bob Dodd down there.
Oh, sure.
And we would talk about accidents. We'd go through all the microfiche until our eyes turned red, and track all the accidents, and then learn by those what we did wrong, what we could do better. With our own accident in Allentown, what we learned was this was a very combative patient, and we had no policy about a combative patient. Oh, and in those days, we didn't have RSI, so we didn't have chemical restraints. We only had tying the patient's hands and feet down.
Yes.
And the ground crew told us that when they put him in the aircraft, he was really struggling and he was unresponsive, but he was combative too. Had we known, we should have had a policy that you just don't take this patient by air. You have to send them by ground. And we didn't, we just didn't think that far ahead. And there was no barrier between, in a BO 105, the paramedic sits right next to the pilot. There's no barrier. And the patient is slid in from the back with the head first. So the patient's head and chest are right almost up against the lap of the paramedic sitting in the left seat. And so we think what happened is he got loose. He was a big kid, about 18 years old. And we think he pushed Patty, the female paramedic, into the pilot because they were only in the air about 30 seconds and came down hard right turn. So we think that's what happened. And so after that, Rick and I would get invited and talk about this and talk to people about barriers in an aircraft, in these small aircraft. Same thing with the bell, where you could potentially have the patient kicking into the pilot and the control.
Yes.
And so we finally got the manufacturers, Bell and MBB, to look at putting barriers in, because, there was all kinds of, oh, no, it's going to cost money. We have to get an SCD and all that kind of stuff. So we finally got that across to people. So that was my interest. I just think that we needed to really develop a team, and we didn't have that. We had pilots doing their thing, and we had medical people confident in their clinical skills, but not confident in where they were doing those skills. And that's what the committee was working on.
Did the committee actually work on safety standards?
Yeah. We weren't allowed to call them standards. We had to call them guidelines.
Guidelines,
yeah. And we would meet with HAI, and also they had guidelines. And then the National Flight Nurses started theirs, and they also had safety guidelines. So we were putting these all together. And I don't know if you remember Jim Smith. He was the president of AIMS in like 1988, I think it was.
Yes, I do.
Yeah. Well, Jim was a good friend because he was also from Pennsylvania. And he promised everybody that we would do a peer review process. And he called it Priority 1 because of all the accidents. Like in 1986, there were 22 accidents and 15 fatalities. And that was just unacceptable. And at that time, there were not 1,100 helicopters like there are today. So he promised this, but he never did get it going. So we took it, the safety committee, and we got Priority 1 started. We did beta testing at Duke and also at University of Columbia, Missouri. And we found out that, we were merely looking at safety and how people worked with each other and training. We completely overlooked.
We're at an airport.
Sorry.
That's okay.
We're at an airport. So we completely overlooked the clinical part. And when we were out doing the beta testing, we discovered that, gee, there's a lot of things here that we should be looking at closer. So we developed all the standards and then took it to Ames, and I did a feasibility study. I checked with other services like JACO at that time, Joint Commission now.
Yes.
And they were not interested in doing any kind of accreditation. They knew nothing about aviation. They said, no, we're not doing this. So we did a feasibility study, and I took it to Ames and to the general membership. And in 1989 or 90, they voted to have a separate organization to do accreditation. And they loaned us $78,000, and that's how we got started with CAMTS.
Right, which was the Commission on Accreditation of...
well, first it was Commission on Accreditation of Air Ambulance.
Right.
And then it changed later, yeah.
To include ground.
Right.
So back to the beta testing, why were those two sites chosen?
Well, Rita Weber from Duke, I don't know if you remember.
Oh,
Rita,
yeah, I know Rita, yeah.
Was on our safety committee, and I forget who, one of the physicians was on our safety committee from Missouri, and those were the two sites that were chosen because they volunteered.
Yes, okay.
And they were very much looking forward to it.
And what were some of the things that you found out through the beta testing, the real important things that you mentioned there?
Well, we found out that the crews, as I said before, they seem to be real confident in their clinical skills, but they were never taught to sort of guard the aircraft. They were never taught to, they knew to stay away from the tail rotor, but we watched, and they were kind of clumsy in how they loaded and unloaded the patient. They seemed a little unsure, and there didn't seem to be dialogue between the medical crews and the pilots that, like you would expect for a cohesive team. The other thing was they weren't aware of. I would ask them, well, what are the FAA rules that you have to abide by? They had no idea that you had to wear seatbelts for takeoff and landings. And I would say to them, so if the patient is coding all of a sudden and you need to attend to the patient's airway while you're landing, what do you do? Oh, well, we'd get out of our seatbelts and do that. So they had no idea how dangerous things were.
So it's really learning the integration with aviation and medicine.
It really was.
Yeah.
And that's what CAMTS has all been about, because you can't do one without the other.
Exactly.
Unless you're negating a lot of things. Yeah.
I mean, like even you're describing your first flight. I mean, it's crew resource management. I mean, and
yes, right.
Helping the pilot and looking out for obstructions, in flight.
All of that. Yeah, none of them knew to do that. And that would be, of course, helpful for the pilot.
Yeah. So you brought together leaders, in 1990 to develop the standards. Who all was involved with that?
So did you remember Dr. Nick Benson from East Care in North Carolina?
Sure.
So Nick, they had their own accident too. So he was very passionate about this. And he became our first chair, and he represented ASAP, College of Emergency Physicians. Mm-hmm. Then Dr. Rick Hunt represented the National Association of EMS Physicians. And Dr. Hunt is with Health and Human Services. You know that he's been doing a lot with the COVID and running conferences. Yes. We still are in touch constantly. And then we had the nurses, the paramedics, the communicators. They were all their groups had just been starting in the mid 80s. We had a representative from there, Karen Johnson, who became Karen Rogers, was the National Night Nurses representative. And so there were 7 groups that started out. And the whole concept was, AIMS was considered a trade organization. So we thought it would be best if we had a separate organization, even though it took a lot more. But as a nonprofit agency, to look at this separate from any kind of influences from marketing or trade. So that's why it was set up separately. Since then, we now have 20 member organizations, and they're all related to transport and medicine.
Right. What are some of the other ones? You don't have to name them all, but.
Well, American Academy of Pediatrics joined about a year later. National Air Transport Association, NATA, that's fixed wing people.
Yes.
And at FBOs. We have on the international end, we had the European Helicopter Association. And so there's also ASMA, Aerospace Medical Association. And we also have the US Transcom is part of our association. And they're the government entity that approves any civilian contracts with transporting military. So they're very important. And so you cannot get a contract without going through an accreditation. It used to be just CAMTS, but it's not anymore.
Yeah, that's very interesting. Now, are they all voting members then?
Yes, yes.
Wow.
Each organization sends a representative, and they each vote.
Yeah, and how often do you meet?
4 times a year. We're meeting for the first time in 2 weeks in person.
Yeah, not virtual.
And we're all very excited about that.
Yeah.
For the last 2 years, we've only had Zoom meetings.
Are you requiring that they be vaccinated before they?
Yes, we are.
Yeah, that's good. Yeah.
Yeah.
So let's backtrack a little bit. So you were elected as the executive director. How did all that happen? Because you had put the things together that.
Yeah, it was. I mean, Nick Benson was obvious the chairperson. He really was passionate about doing this. And since I had all the data and all the background and the standards, they just asked me to be executive director. So I didn't have to, but I left my job in Allentown, and we were moving at the time anyway in 1990, because Rick was asked to head up an FBO for Rocky Mountain Helicopters in South Carolina. That's how we ended up there. That's
how you were in South Carolina. Yeah, I think that's where I picked up knowing you is when you were in South Carolina.
Yeah.
I think it was when West Michigan Air Care went for the accreditation.
That was quite a long time ago.
Yes. Doesn't seem that long, but you had to. Well, I guess first of all, where's the funding now come from? I mean, you had that initial amount. Was that a loan, or was that actually?
It was a loan of $78,000 that we paid back in 2000. Was our final payment. So paid back in full with interest, and from then it was just the programs that applied for accreditation. That's what supports us. We had one grant that was given to us for $500 early on. And that was it. That's all the funding we had. And actually, we almost ran out of money in probably 1993, because, had very few, people were not running to become accredited in those days.
Yeah.
And it wasn't until some would get accredited, and then competitors would say, oh, well, we're going to get accredited too. And I mean, you didn't have to do it. It wasn't required. So why we have enough to do. We don't need to do this too. So it took a while for it to catch on. I've always had the office in my home to save on money. And actually, until I moved out here, it was still in my home. And we finally were forced to get a real office. but what happened was we had built a home in South Carolina for Rick's parents who both expired. They were living with us. And so the whole downstairs level was perfect for an office, really. And so that's what we were using. And I had two helpers in the office, and they come and go. They would come and go from my home, and it worked out okay. And while we were really getting lower in our finances, I was only really getting paid for specific tasks that I was doing, not salaried. But we started to recover then around 1994, 95, and keep adding on. And so that's how we're supported.
Yeah. And what was the big impetus for people to get accredited? Because what's the percentages of programs now that are accredited?
That are accredited today?
Yeah.
It's, that's a good question, Ed. It's hard to say. I guesstimate maybe 70-75% helicopter programs are accredited.
Yeah.
But when you say program, that doesn't mean what it used to, because there's so many conglomerates and mergers, and it's hard to say about what programs, but about 75%. In the early days, I can tell you Roseanne Krantz was one of our early site surveyors, and she was in Fargo, North Dakota.
Sure.
They were the very first program. And it seemed like one, toe dip in the water and then a few others, and they would start coming in. And I think with those strong program directors, that was helpful, because they were also on like the Ames board and that kind of thing. And they would talk to each other about, well, what did you learn from this? And was it worthwhile? And was it worth the money? And we have always tried to keep costs down as much as possible. Even our training and everything for site surveyors, that's one of the things we emphasize. They're not out there to have 5-star dinners and that kind of thing. They're not even allowed to accept dinners at, different, when they go site visit. So we try to keep the cost down for everyone.
Yeah, that's fantastic. Knowing, some of that early history and how you put this together. I think the other thing, maybe early on, some of the reluctance is that there wasn't any advantage like the joint, where you have to be for reimbursement purposes. So
exactly.
Is that something that is being looked at?
Oh, we've tried over the years. They're not, CMS is not interested, really? Not at all.
Why? You think they would be?
You think that, having everything set out for you, that would be easy thing, well, if they're accredited, then they can get reimbursed. They're just not going to do it.
Yeah.
And you know what, Ed, there were 10 states like in the late 90s, early 2000s, that said you have to be CAMTS accredited in order to get a state license. Well, that didn't work out well either, because we got sued in 1993, and that was a very expensive lesson. And so we've encouraged states, and there's only one, Washington, now, that requires CAMTS accreditation. We've encouraged the states to do like a deemed status, so that if the program's accredited, they probably won't have to go through all their licensing hoops, because that's an advantage. But we've encouraged them not to say in their rules that they have to be CAMTS accredited, because it puts the onus on us. And our lawsuit was very costly.
Yeah.
Our errors and omissions insurance went from $3,000 a year to $33,000 ever since.
Well, didn't they do some things where it had to be CAMTS or the CAMTS equivalent type of thing? Didn't some of the states do that too?
What they say is you have to be compliant with the CAMTS standard or with accreditation standards in some cases. And Arizona doesn't issue a license until they see that you're accredited, you have to see the certificate of accreditation.
Yeah, I remember reading about Colorado, and then didn't Michigan do something with equivalent?
Michigan had a C of N process, so a certificate
That's
of
right.
need.
That's right.
Yeah. Mm-hmm.
Yeah. Well, you had talked about the site surveyors, and Roseanne, explain how that all got started and how you developed the training and how many surveyors do you have now?
We now have 60 surveyors. In the beginning, I went and took the American Association, if I get this right, of rehab facilities had their own accreditation, and they invited me to attend their training. It was a 3-day training program that I built our training program on because it was excellent. And what they did was they did like a mock survey as part of the training. And of course, the first day was all policies, standards, and you have to understand the standards. And then they did a mock survey, and then people were given exactly what you would get in an application. They had to review all that and then do interviews. So they test your interview skills. And it was really funny because one of the people in my little group, they would separate you into groups, was a psychologist, and he got so upset and worried about this course that he threw up his papers and said, "That's it, I can't do this," and he left. Because you're tested on how you're going to word things. Naturally, you're going to get into some situation, and that's what we test in our training too. It's more about how you handle things than even how you have to know the standards, of course, but you're going to get into situations where people will not be happy with what you're telling them. And of course, always they want to know, well, do you think we're going to be accredited? And site surveyors are always told that's not your decision.
Yep.
You just tell them what your findings are, and that's it. And so we developed that in 1991 was our first class. And then we've done like 8, 9 classes every couple of years we do. And we usually invite 12. We keep it small because there's too much information to spread out over. And we like to, handle everyone's questions and concerns. And so it's usually people, we say they have to have 4 years experience. We don't have any site surveyors with less than 10 years experience now. We have all really, really experienced.
And what is their backgrounds? Because it does vary, right?
It varies a lot. So nurses, medics, pilots, we have a few mechanics, we have a few communicators, there's hospital administrators, and there's physicians. We have a few physicians. There are certain places that ask us, could you send a physician? Not so much anymore, but it used to be that way. Because they had physician teams, so they wanted a physician to.
Got you.
So we try to tailor it as much to what their needs are and what their program is. And so, for example, we have fixed wing pilots and also rotor wing pilots, and pilots who do both. So for a long distance fixed wing service, we wouldn't send a rotor wing pilot. That just doesn't work. And that's why we have so many site surveyors, because you need to tailor it a little bit to what the program.
So it's usually some type of clinical background and then clinical aviation are the two areas. Yeah.
Yeah. And we like to now accept people who we'll be interviewing for a new class in a couple months. We like to accept people who have been through the CAMTS process themselves, because they can understand a little bit about what they're supposed to do and what they're testing against. Yeah.
Yeah, I've always thought it's been great to have someone. I've been more the program director of programs that you have someone that is a CAMS surveyor, because I think you just learn so much and you're up to date with standards and so forth. So then when you go through the process yourself, you're much more ready for it.
Oh, they don't do this for the money, because they're only paid $400 a day. Plus travel and expenses.
Right.
But they all think that they can take things back to their own service. And they're not out there really to be consultants. They're out there to just document their findings. but many times they can, if they're asked what would you do in this case? And if they're from another service, they're told you never bring up your program. You could say things like, well, what I've seen in the
Yeah.
past, or
Yeah.
this is what I've observed or something. So it's tricky.
Yeah. I think the nice thing, though, even for someone that is a surveyor, that your program is that you learn a lot by going to other programs.
Oh, you do.
You learn things that you can bring back. Is there a rule about bringing back specific things, or if you've got ideas? Okay.
No, that should be an advantage for you, and absolutely you can bring things back. Now, if they're going to maybe copy something, a policy, of course they have to get permission for that. But as far as bringing concepts and different ways of doing things, that happens all the time.
Yeah. The other thing that I liked and I used, I think the last 2 times when I was at LifeLink, is having, a mock survey done through that. Talk about that program.
We have a consulting arm, and it's completely separate from accreditation. So there's no promise that you'll be accredited if you hire a consultant.
Sure.
But it's good because it'll take you through, especially if you have specific needs. Sometimes programs contact us and say they're just not doing everything they need to do for quality. Could you send somebody who's particularly advanced in quality management? And so those are the kind of things that we do. Consultants are senior site surveyors or former board members.
Yeah, so they're not actually, so they can do surveys as well.
They can.
Yeah.
But if they consulted with a program in the past 3 years, then they wouldn't be assigned to do a survey.
Well, what I found particularly helpful with the mock, and I, had a little bit of pushback from some people, this will be fine. It was the new people at your organization.
Yeah,
and when you have the consultant, they walk through as a consultant and make you feel very comfortable.
Right.
And I know in getting feedback from the staff that was, new into their positions, that, boy, that was really helpful, for us to prepare for the real survey.
Oh, good. I'm glad to hear that.
Yeah, no, I'm a big proponent. And I think if anybody's listening on this podcast, you ought to look into that, because even if you think that you have everything down, there's stuff. And I've been at programs that, we're fine. We're the top of the game. I said, I will bet that there will be things that we're not doing as well as we could. And every time there was. So, so it's such a wonderful process for people. You had talked about the number of air medical programs that are accredited. When did the ground piece get added, and how many ground transport programs now? And are they part of the air medical program, or are these standalone?
Not necessarily. We changed our name in 1987 to Commission on Accreditation Medical Transport.
Right.
And we even have one boat that's accredited. But anyway, the ground piece came about mostly from the specialty teams, because they contacted us and they said, we don't have anything like this. We need it for our teams. And so they helped us build those ground transport guidelines and standards. And so that started in 1987. There's about 5 independent ground services that are accredited, but for the most part, they're part of either a rotor or a fixed wing service. In addition to, so we would look at both.
I thought so. It's
look at both.
And it is the CAMTS ground. Is that more critical care ground?
So the policy is, if you have a critical care ground service in addition to your air service, and you're advertising and accepting requests for that service, you must include that in the accreditation process, because you're using the same everything. But if you're doing ALS, BLS only, you don't have to include it. And it gets confusing, because some programs use a ground service if they're down for weather or maintenance.
Yes.
We don't say that's a dedicated service. You don't have to include that. unless the numbers start increasing and increasing and you find yourself, you're just going to offer ground, then that has to be included if it's critical care.
Yeah, and then in those cases, I think I ran into that a program where you have you're using a ground service like only when you're down for weather, but then the compliance that they had to have as far as the equipment, et cetera, on the ground unit, which they might not have had in the past.
Right. Yeah. It gets very confusing because business, the way it's now, it's completely opposite of how it used to be when we had one helicopter at one hospital. It's a lot different now.
Yes. Yeah. Big time. I mean, that's another whole podcast, I think.
Yes, it is.
So how does a program, it's an independent program, would they have both the CAS or that's the Commission on the Accreditation of Ambulance Services, which is more the ground piece, and CAMS, or?
Some do. CAS, we're real close with the executive director there. They're more, I guess you could say, financially focused. They worry more about the business end of
I see.
services.
I didn't know that.
And they do critical care too, and they do ALS and BLS primarily. And they started around the same time we did.
Oh, is that right? Yeah.
Mm-hmm.
I don't know much about their standards, but I was wondering, with more programs getting into ground or independent grounds, because the crossover from ALS to specialty, and there's really not a critical care designation.
We're struggling right now. The board is, and we meet, and in fact, we're going to talk about this again, because what we're finding is across the country, critical care ground units are mostly 2 paramedics or a paramedic and an EMT.
EMT, right.
And what they call a critical care paramedic could be anything from a homegrown course to the course in Baltimore to taking the FPC certification, which none of those really mesh with our standards, because in our standards, we say, if you're the lead person and you're a paramedic, you have to have 4,000 hours of critical care. And who's going to get that? Because they're not allowed to work in critical care for the most part in hospitals. And so we're struggling with this because our standards don't match what's being done. But on the other hand, we don't feel that the critical care that's performed by many of these services are what up to our expectations for critical care.
Right.
So it's interesting. We're looking at this from all angles and how to help the programs so that they are actually training in critical care. A lot of them feel, because they've been doing this for years and years and years and calling themselves critical care, that should be good enough, So it's interesting. It really is.
Yeah. Is it because there's not a specific reimbursement for critical care? Would that help?
That would help. Would help. And the government doesn't designate even critical care that way. So it's
there's what specialty care, I think.
There's specialty care. That's what they call critical care. Yeah.
Right, yeah.
And that's confusing because we call specialty care neonate pediatrics.
Right.
So,
yeah. So having been the director of a number of programs, I know the standards are revised periodically. And is there a set schedule on when CAMS does this? And then when a program is coming up for accreditation, how do you know which standards? I know that was always, we have the new standards, but yet we're under the old standards. And I think we've even said sometimes, let's prepare to the new standards anyhow. But so how does that all work?
Well, the standards we try to do every 3 years. This, because of the COVID delays and because we're adding mobile integrated health in the next set of standards, it's going to be another year until those come out. So that'll be the 12th edition. We're now on the 11th edition. Anyone that applies during the time that the next edition is printed and published, like say October of 22, if you applied or your reaccreditation is due, then you would still be under the old standards until 6 months later.
I see.
So we give a 6 months leeway
6 months
there.
lag.
Yeah. Mm-hmm.
And
then, of course, everything changes because not just the standards, but the whole program information form that's now online. And we have to change all of that to match with the standards. So it's a process.
Yeah, that's called the PIF, right?
The PIF, yeah.
That's right. I know from reading some of the material that you use the ANSI, or American National Standards Institute. Why does CAMTS use that, and what's that mean exactly?
It means that they have accredited us as a standards producing organization.
I see.
And recognized us for that. So we have to go according to their process, which is a little more detailed than what we did before. We always had a standards committee, but now every time this is all open and transparent. So every time there's a draft, it's posted on the website. If people do respond and send in their suggestions or ideas, we have to respond back to each one of those people. So Dudley Smith, my associate, has been excellent in handling the standards and the ANSI process for the standards. And we're proud of that because we kept being asked, well, why aren't you accredited by somebody? Well, who? I mean, there really isn't an overall agency that says you pass accreditation. For accrediting agencies, you can start an accrediting agency from a real estate office, for example.
Yeah. So is that a form of accreditation though? Or is it
not in the true sense that we're used to, but they call it you're accredited as a standards producing, and CAS is in the same category. They also have that.
But do they come in and review things? I mean, is it a process?
Yeah, they don't come in ordinarily because it's mostly shuffling papers and things back and forth. And thank God for email now. But that's how it usually done. If they feel like they want to visit, they certainly can, and that they leave that open as an idea.
So is it in like how you develop the standards and?
It's mostly the process, how they're passed and who passes them and how are they voted on and what is the committee's role, who's on the committee, that
and how they change and how they're approved. Yeah,
right.
So CAMTS has also went global. 2015? Tell us about how this happened. How has it changed the organization, and has it influenced any of the standards?
Yeah. That was really interesting. I knew Stefan Becker from Swiss Air Rescue for many years, meeting with him at HAI. And I would always say to him, why don't you become CAMTS accredited? Why doesn't Swiss Air Rescue? Oh, he was real reluctant. Well, he finally got EHAC, the European Helicopter Association, to say that, well, maybe they should join CAMTS. And so we sort of got together that way. They're no longer really a member because URAMI is also an accreditation agency for Europe.
Yes. Yeah.
But we decided that we're going to do CAMTS Global because we had applications. The very first international we did was actually Air Rescue South Africa in Johannesburg. That was our first one. And we kept getting applications from Bangkok, from Thailand. And that was before we even developed Global. But it helped us because as we went out and tried to fit what they were doing with our standards, it wasn't exactly a match, especially when it came to clinical training and, local rules and their guidelines versus FAA and that kind of thing. And actually, the European EASA regulations are much stricter than FAA is.
Oh, really?
Even the Canadian CAT is stricter than the FAA. So we learned all of this by going out and doing, and we'd always done Canadian services. They're part of CAMS because we say North America is CAMS, but CAMS Global is anything outside of North America. We now have a couple services. Embrace, it's a children's specialty service in the UK, and one of their lead medical director is on our board of directors. And then we have Swiss Air Rescue. They've been accredited now for several cycles. The South African people dropped, and they're no longer part of CAMS, but they were a learning tool, you might say, and helped us decide what standards. We changed the standards to match kind of what's done outside of the North America. So there are different standards, but not entirely. Many of the management and QM and that kind of stuff is the same. It's just mostly the clinical requirements and that sort of thing that are different. And so those standards were changed. We incorporated they don't call it incorporated, they call it registered. We were registered in Zurich in 2015.
Oh.
And that board is smaller. That's Stefan and I are considered the founding members. The board is made up of John Greinick from Flight Paramedics, because they're now international. So he serves on both boards. And Ashley Smith, who's with NADA on our CAMS board, serves on the CAMS Global board as the treasurer kind of person. And then we have Dr. Doon from Bangkok, who's serving on our board of directors. So when we set up a meeting, we have to set up for Pacific time zone, Eastern, European, and Asia.
Yeah, that's difficult. So it's a separate organization?
It is. It's a separate organization.
I see.
Yeah. Mm-hmm.
And it's chartered in Zurich then?
In Zurich.
I got you. And just an example of maybe some of the differences, the big differences between the standards, the North American standards, and some of the others.
The aviation parts, we don't have as many, I guess you could say, pilot training and pilot requirements are much stricter in those countries. So they meet and exceed most of what we had in the first place.
Got you.
The medical part, the clinical, is interesting because in Europe, for example, paramedics are often trained more so than nurses are. They have a higher level of training. So, and certifications like ATLS is sort of global, but not all the other things. Like PALS isn't always global. They might have their own PALS course certification. Yeah. So we have to look at what their certifications are that are accepted in their country. And we had to change a lot of that. The communications is a little bit different too. We don't see, if you ever have an opportunity to visit Swiss Air Rescue, their communications department is a whole building almost by itself, because they have to do both helicopter, fixed wing, and it's fantastic in many languages, because of course in Europe you're going to have more than English to worry about. So those kinds of things are really interesting. When we put together a site surveyor class for that particular CAMS Global, we have some wonderful people that speak several languages. There's a doctor, a physician from India who just speaks probably every language you could think of. And she came to, I was amazed. She came to our meeting, site surveyor training, and knew more than I did. She must have memorized every standard because she knew them all. You couldn't trick her on anything.
Wow. So are the site surveyors then, they're from those countries, they're different?
Yeah, we have a few from Germany. We have a few from the UK, and a pilot mechanic from Switzerland. So
Yeah.
there's a couple there. And we have one from Bangkok, a physician.
Yeah. Wow.
And
So,
that was the other thing. The physician, the makeup of the teams is totally different. In Europe, it's not acceptable for a nurse paramedic team. They mostly want physician
right.
and nurse. So that's a little bit different. And that's true also in Bangkok. But the nurses there, we were impressed with they have to go through what the Air Force goes through as far as their training in aviation. So they're a little bit ahead of most what we see everywhere else.
Yeah. Did you, from that experience, and what a wonderful experience to have all that, to see the different ways things are done. Did any of that come back to CAMTS North America? Did you learn some things that, to change some of the standards here?
I don't know if we changed any standards. What I think what changed were attitudes, because we have mindsets and it has to be this way. And some people are black and white and some aren't. And so when we look at how people comply with the standard, it doesn't always have to go this way. There could be other innovative ways. That's mostly what we learned, and how it broaden the way we look at compliance with standards.
Yeah,
that helped a lot.
Yeah, that's a really good point. Good, something that you learned. So we'll continue on here. So CAMTS has vision, mission, values. When and how were they developed, and what exactly are they?
Our mission right from the beginning didn't change. We want to improve patient care and safety in transport. Yeah. So that's it. Our vision is that all patients will be transported by qualified crews in the safest manner and by the most appropriate transport vehicle, because that's where we find a lot of problems. Yeah. And our values are fair, ethical, consistent. I always have to look at back, accountable, and patient and safety focused. Yeah. Those are our values. Yeah. And those actually weren't developed for a couple years, because it took actually, do you know Dr. John Overton? He joined our board.
Yes. Mm-hmm.
Yeah. Well, John brought a lot of this with him, as well as Just Culture. He's the one that came up with the Just Culture training. And he's the one that, was, well, your values aren't, you need better values. And he's the one that brought it. And this is the best thing about having representation from different parts of the country and from different organizations, because we all live in our own experiences. Yes. And he had great experiences that he brought to the board.
Yeah, that's what my comment earlier about, there's nothing that we can learn, we're doing everything just great in our own little bubble here. So just going on your comment, most appropriate vehicle, you seem to emphasize that. What is it about that?
Well, with increased competition in the United States, I'm talking about, mm-hmm. It is sometimes difficult for helicopter services to even survive, because if you don't have, and you know this better than I do, Ed, if you don't do a certain number of flights, you're not going to even cover your fixed costs. And so there's a lot of competition. We did a video a couple of years ago on helicopter shopping, because, yes. We would find that if you didn't get a service, you're calling a service and they said they can't come, then they'll go to another service, and the weather's the same no matter what. And you're going to end up with maybe someone having an accident, and that's actually happened. So we
South Carolina.
Yes, absolutely.
I was there during
that's
that.
Right.
Yeah.
That was a prime example.
Yes.
So competition is really stiff, and if you're trying to do, when in our utilization review standards, we talk about how do you get back to people? Do you get back to people if they've called you and you've trended this? on a consistent basis for inappropriate helicopter transport. And what we'll hear from most people is, we can't do that because then they won't call us anymore at all, kind of thing.
Yeah.
It's a fine line they have to walk. I realize that. But really, you can't be consistently using the helicopter for things that could have gone by ground.
Yes.
And so we really look heavily into utilization review when we're seeing a program.
Yeah, it's tough. I know I've faced that too. I said, we need to tell them, well, then they'll just call the other service.
That's right. That's right.
And say, you're not going to do it, really rather hard. Than, really learning from the experience and also the cost to the patient too.
That's right. Yeah.
So, and moving on, you've recently created an award in the memory of Dr. Ralph Rogers, who was the chair of CAMTS from 2000 to 2016.
Yeah.
And I knew Ralph well when I was at West Michigan Air Care, and he was at Aeromed up in Grand Rapids, was just to the north. And so we worked together a lot. How did the award come about, and when was the first recipient announced?
We wanted to honor Ralph because he was just a great chair. He was one of those people that could get everyone together on something. And I must say that our board never has fistfights or out and out disagreements, like we could say about maybe the Congress or something. But he had this special way of bringing up a point without saying you're wrong or you're right. He was just fabulous. And so we miss him terribly. And we wanted to, and of course, Karen was on our board too, his wife, but they met through CAMES. So Karen and Ralph met through our CAMES board. And we wanted to honor him in some way. And we thought, well, he was always really influencing education, and what could we do to educate anyone who wanted to go further in air medicine or ground transport. And so we advertised for donations for a couple of years, and we finally were able to award Dr. Adam Gotchula from University of Cincinnati, and he is doing also a fellowship in anesthesia at the University of Michigan. This guy is like into everything. But he wanted it really so that he could attend MTLI, because all his money, he said, was tied up in school and going further. And so he was the first recipient, and that was just last fall. He
right.
Did that.
Yeah, I saw that. And that's just wonderful to recognize Ralph. I knew him. I think I asked you before. I had a quick little side story because I asked, was he known as being a techie when he was on the board? And I remember I'd have lunch with Ralph. We'd meet somewhere in between Grand Rapids and Kalamazoo. And he said, I just got this new computer, and it's got 1 megabyte, of memory. And I remember both of us going like, oh my gosh, that's just incredible. But he was always pushing the envelope with tech. And of course, I do the same.
I'm forever grateful, absolutely, to Ralph, because we used to have all the application and materials they send us would be in notebooks this high. And and we'd have to carry these notebooks. This is what kept me in shape, I think. We had to carry these notebooks. In fact, we had a board meeting in Albuquerque one year, and I'll never forget this. I'm trying to carry these 2 stacks of notebooks across the big street there from the hotel, and I dropped them, and all the papers flew out everywhere. Oh, it was awful. And so when I was telling Ralph the story, he said, "That's it. We're not doing notebooks anymore. Everything has to come in by computer. We're not doing any of this paper stuff anymore."
Oh, that's a great story. Yeah. You're currently working on developing some mobile integrated health standards with a special committee. And what's this all about?
What we do when we're doing an entity that all of us are not completely familiar with is we go out to the community and see who's actually doing these types of services. We did the same with our special operations standards that we did 2 years ago. This committee for mobile integrated health is made up of about 10 people from around the country who have been doing community paramedicine, telemedicine, those kind of things for several years. Some of these people have been doing it for 10 years, and I didn't even realize it was going that long. And so they're helping us develop these standards. It's funny because we take the standards we have for CAMTS and have been paring them down, separating them out, and that kind of thing. At least we had a base to start with. But we will read something and we'll say, well, that doesn't make sense for if you're just going out to check somebody's blood pressure, kind of thing.
Wow.
So it's been a great process. And we're about to put out, I think, a third draft of that. Actually, Dudley will be attending EMS today. And one of our committee members is going to be giving a talk about community integrated health, and she's going to be talking about the standards we developed so far, even though it's only a draft.
Yeah.
So we're hoping to get those out next year.
That's wonderful. Is CAS doing the same thing?
They have some standards in their new standards that they put out, but I have no idea how they developed those. Who they used or whatever. I don't know.
Do you know how many community programs there are now? I mean, it's grown, right? I mean,
it's really grown. And, it has, this is the future of healthcare, I think. Let's face it.
Yeah.
And that's why at first we were, Dudley said, well, I don't know if we should do this because nobody's going to apply for accreditation for this because most of them there's like 1 or 2 people that do this, in some cases. Some cases they're part of a hospital. But, and we thought about it and we said, no, it doesn't matter even if somebody doesn't apply for accreditation. At least the standards are out there for people to follow. That there's something out there. So this has been a great process. I learned about it too in Bangkok when I was there several years ago. They had a very sophisticated telemedicine process.
Wow.
That was unbelievable. So we're way behind in the United States. We really are. And that's why we got to get these standards out.
That's interesting because most of what I read is usually it's the ground-based services that are doing this. Are there some air medical programs that are doing
yes.
this?
Med Center Air is doing.
Oh, okay.
Yeah.
I did not know
so
that.
They're on our committee. There's very few, but they are more and more starting to integrate this.
Yeah. I agree. I think it is the future. Let's talk about your staff at CAMTS. I know it's not a big staff that you have, but I know your assistant executive directors very well with Dudley from working on the AIMS board and also the Medical Transport Leadership Institute, which we were in, and then Jan Eichel, worked with me at West Michigan Air Care as the chief flight nurse. Tell us about what they do and also what other staff you have.
Well, Dudley is considered the administrative associate executive director because he does a lot with standards. He helps me with a lot with the policies, and he's kind of our sounding board. He's been in this business almost as long as I have, and we've known each other all these years.
Yes,
he's been great. Jan is our clinical associate executive director. It is difficult for me or Dudley to even be current on clinical things because we haven't done them in a long time.
Yeah.
So she's been excellent.
Great.
She does the quality management service for CAMTS. So she does our internal quality management and then posts her findings on our website. We try to be as transparent as possible. So between the two of them, I have excellent help all the time. In the office, I don't want to lose my people in South Carolina because they've been with me. Shelley's been with me, I think 15 years, and Gigi about 7 years, 8 years. She'll kill me if I'm wrong, but that's probably what it is. And they've been great. So Gigi does all the scheduling I mean, all the scheduling of site surveyors, and that's a task
Oh,
because
yes.
you're trying to get people's schedules with the hospital or the program schedule, and are they acceptable, and who has a conflict of interest, and it's very complicated. But she does a great job, and we schedule anywhere from 20 to 24 each quarter. So that's pretty hefty job for her. Shelley is our bookkeeper, but she's also the person that anybody calls if they have any problems with the online PIF or anything that has to do with the business end of the office. She's fantastic. She's my right hand, really.
Yeah. So when did Dudley come on?
He was with the Ames board, and he came on because I think as well, he was a site surveyor for a long time.
Yes.
So yeah, so even before he came on the board, but about 8 years, maybe it's 10 years ago, he started on the board and he was representing Ames at the time.
Right. I remember he was the Ames
Yeah,
rep.
he was the Ames representative. It was even probably before that. But then we needed another position. I was way over my head. And so we hired him as the associate executive director. And that was probably about 10 years ago.
Yeah. And then when did Jan come? I lose track of time.
Me too.
It's been a while now, isn't it?
Yeah, I think Jan's been on since about 5 years ago.
Yeah.
And we found that we needed yet another person. We run pretty slim on people, but so far we're keeping up with what we have, and we'll see what happens in the future.
Do you see the staff growing with all the additional work?
It might. We'll have to see as time goes by.
Let's talk about COVID-19. I mean, I've been following, if you've listened to some of the other podcasts about what programs have done, what the initial reaction was. Even had a podcast that I talked to a number of people. Geez, how is this affecting you? But it's affected everyone. And how has it affected the accreditation process and site surveys? What have you had to do differently? But the other thing I look at is, what are we learning from that maybe we can carry on, that we don't have to go back to the same way we did things? So
those are all good questions. So last fall, we started to do site visits, partial virtual and partial in person. So we wouldn't, trying to keep the mitigation of the spread of the virus as low as possible. We would send one person out, and one person would stay back and do virtual interviews and tours and that kind of thing.
I see.
And then, and of course, we didn't have the vaccination back then, so they had to, we had very specific things they had to do in attestation forms they had to sign. So everything was above board before we even went out. We had no problems at all from that. But then when we started the spring 2021 surveys, we decided we're not going to send anybody anymore, because things were like January looking pretty bleak. So from then we started to do all virtual surveys. And so the policies again had to change. And so when you're doing a tour, or you're trying to, for example, you're trying to look at somebody's medications, are they outdated or anything like that? It's very difficult to do virtually. And so we developed a lot of procedures for how to conduct a virtual visit.
Wow.
We did about 24 virtually in spring. We're gradually coming back now. We only did 3 out of the 24 for the summer meeting that are virtual. And we even changed one of our accreditation decision policies, because we felt that a program wasn't getting really a fair, review by total virtual. And so if they were lacking, and mostly what we saw with programs was they couldn't keep up with some of the training. A lot of the courses were canceled. You couldn't get into the OR. So, for intubations and all this, on and on and on. So we had to give a little leeway. So if a program was coming up for reaccreditation and they had a virtual survey and they didn't have full accreditation last time, we might do a conditional accreditation, meaning if they have a year to come back to us again, and then we'll come out and see you. So it gives them a year's time. And so we had a couple conditional decisions as a result of that. How it affects long-term, I hear a lot of people that work in offices say, oh, we don't even need the office building anymore. We'll work from home. No, it doesn't work with site visits. I truly don't think so. You can see what you can see in this little screen, but you don't get the general gist of things unless you're out there. It just is not the same. And we want to make sure we're fair to everybody. The programs now that are saying that they want only virtual visits are mostly like children's hospitals who still have very strict guidelines about visitors and that sort of thing. And who we send out, they have to be vaccinated or they're not going to be sent out. And that's just, I've had a lot of people say to me, that's not legal. That's not right. That's, I don't care. Yeah. We're not taking your occupation away from you. We'll find you something else to do. They're only paid by site visit. They're not really employees. They're contracted. So we're not putting anybody else at risk, and we're not putting site surveyors at risk. We don't have to.
There's a lot of hospitals you read, are requiring, going and just saying no. I mean, there was controversy at one of the hospitals that was a member of Lifelink when they required flu vaccine. This was a few years ago, and that was a big controversy. But you can see with COVID, I mean, geez, why people don't want to. And
it's
now
beyond
with this,
me.
now with this Delta variant,
I know
it could be, Missouri's going through quite a bit right now. Are we opening up too quickly because people aren't, they get rid of the mask mandate, the CDC, WHO has not gotten rid of that guideline. And I pretty much personally following that. I think even, I bike a lot and I have a mask that I'll pull up if I'm around too many people. I mean, I just don't want to take a chance. And Minnesota is actually pretty high vaccination rate, but there's other areas of the country that are not. And the Delta variant is even more virulent.
It's scary.
Yeah, it is. It really is. And then you don't want to see it keep mutating.
That's right.
Which, gets around possibly some of the vaccines. So at another area, how many other accreditation agencies are there for air medical transport?
There's two others in the world, and there's URAMI, European.
Yeah, you talked about that, yeah.
And a funny story about that is I was at a conference in Interlaken about 2002, I think it was, and I was invited to speak about our accreditation. And Dr. Weinlich came up to me. He's the one that invited me. And he said, I have a surprise for you. And I said, what's that? We have our own accreditation now, and we use your standards. That's how that was introduced.
Yeah.
And what do you say? I mean, it was 2 minutes before I was supposed to go up and speak about CAMTS accreditation.
Wow.
And when I took it back to the board, they were not happy, but there wasn't anything we could do, at that point in time. Not that I could think of.
Yeah.
So that's how they started out. And there's another accreditation agency called NAMPTA, and I can never get what it really stands for, National Air Alliance.
I had to look it up myself. So I have a National Accreditation Alliance of Medical Transport Applications.
Okay.
Doesn't make sense to me, but.
They started out for kind of borrowing standards.
Yep.
And I still to this day don't know what experience level they have. They have Griff, who's a very nice gentleman, and his background was real estate. He was in real estate in California. So as I said before, anybody can start an accreditation agency, and That's what they did.
I,
And they have about 30 accredited services.
yeah, I know you can't get into the details, but there was a lawsuit, obviously, between CAMS and NAMTA, and but why did they develop?
I'm not sure. I
Yeah,
think he felt that he made a lot of money in real estate. Let's try something else. And
yeah,
that's why he started this.
yeah. I think as when I was the Ames president, now called chair, I think there were some programs that were, they would call me, as the president chair of Ames, like, well, you got to do something, and I can't do anything about my own program. What do you think? We have, Ames has just got one seat on the board, and I said you've got to take that up with CAMS. So I don't know if that was part of it, but
we're not afraid of competition at all.
Yeah.
We're really not. And but you'd like to see it at least sort of equal levels. And they don't have representation like we do from all the major organizations.
Yeah.
So it's a different process.
And they too, I think that was part of the lawsuit too. They too took the CAMS standards and sort of used them as their basis. Eileen, you've written a lot of articles. You have now a regular column that I read all the time, the Air Medical Journal. Do you enjoy writing?
Yeah, I'm probably a better writer than I am a nurse. I don't know. I've always loved history and writing, and took many courses in English and everything. So I love to write. I'm doing a book right now. Did you want me to talk about that?
Yeah.
Okay. I've been working on this for several years. And what I thought about was the people that I met early on that had a part in starting helicopter air ambulances in the US. And so I interviewed Marius Burke from Air Methods, who I didn't find out till much later was one of the Air America pilots in the 70s who did one of the last flights out in Da Nang, Vietnam.
Oh, wow.
He has a fabulous background.
Yeah.
And I knew him as a DO for Air Methods. And Russ Spray, who everybody knows because he was Rocky Mountain Helicopter's first person that started with Denver Flight Relief as the very first hospital-based helicopter program.
Right.
Russ has very interesting business stories to tell. And Dr. Alistair Kahn, who was our current chair on the CAMS board. Dr. Kahn's from Boston MedFlight and head of the Massachusetts General Emergency Department. And I've known Dr. Kahn for 30 years because he and Dr. Rhodes at the program in Allentown both served under Cowley in Maryland. And that's how they knew each other. So Dr. Kahn has these great history stories about Dr. Cowley and how that trauma center started from a 4-bed unit to what they are today, and how the golden hour started and all of that. It's just fascinating. And I thought, well, these are the 3 entities that have come together to do air ambulance in the United States. Really, they're the ones that combined. It was time and space for that to happen after Vietnam. And so I bring these together, and then I talk about how I observed all this through these 3 people, their interviews. And I'm working with a publisher now on the island. Actually, this is a perfect place because I don't know if you know John Nance, who wrote the very famous book, Blind Trust. They even made a movie out of it.
Yes.
About the initial CRM and crew coordination in an aircraft. John actually is on CBS or one of the big stations as an aviation advisor. You'll see him every once in a while featured. And so there's famous authors that live on this island. It's really, really fascinating. So I'm working with a publisher who's helping me too, because I don't know, spacing and page this, page left, and where to put pictures or quotes and that kind of thing. So he's helping me with that, and I'm hoping to get that out next year.
That's absolutely wonderful that you're doing that. Actually, it was Tammy Chapman that said, Eileen's writing a book, and I said, no, I didn't know that. So I said that'd be great to interview her for the podcast because I've wanted to talk to you about CAMTS. So the working title is, you think you're going to stick with that, or?
I don't think so.
Yeah.
My publisher doesn't think that's a good title. I just put helicopters in medicine, but he's got some other ideas.
Yeah, I think that's great that you have the love of history. And I think one of the articles that you wrote too, I think it was a chapter in the air medical crew curriculum, the
Yeah.
history of air medical transport. That's fantastic that you're doing that. And you've become so much a part of the history of what we've done too. So that's
Well, when I started this book and my publisher first read it, he said, well, where's your chapter? I said, well, this isn't about me. And he said, no, you're an important part of putting this all together. So no, you have to have a chapter. So he talked me into it.
Yeah, he's absolutely right, because you have so much of the history. So you've also received two very prestigious awards in our air medical community. The first being the Jim Charlson Award that's given for significant contribution for air medical safety. That was in 1991. And the other, the Marriott Carlson Award for outstanding contributions to the air medical transport community. That was in 2000. Congratulations on both those awards. I don't know if I know of anybody that's received both of those. And so that's quite an honor. What were the specific things you were recognized for?
I think mostly just for, starting CAMTS and recognizing that safety was an issue in that original Jim Charlson Award, because I'm the one that brought safety guidelines to Ames, Ashbeams at that time. And actually, I have to give my husband, Rick, a lot of credit too, because he and I would be the ones to go around and lecture to people about safety. He's actually produced the first communications course for a communication center that we took to Ashbeams. So we developed a lot of those things and got them out there. And that's kind of what they were recognizing me for. But I like to say that nobody does this alone. And I mean, I've had great people around me, and especially Rick has been there. He's our IT guy and he does it all. So he's my aviation advisor. So if I have any questions about aviation, all I have to do is shout it out. I don't even have to research it.
Well, but it takes the leadership to bring it all together. And I think that's fantastic. Congratulations again. Let's talk a little bit about your personal life. I think you, originally from Eastern Pennsylvania. Talk about Rick. How did you meet Rick?
Well, I was the newly chief flight nurse, and Keystone sent Rick. He was just back from Alaska. He did geological camp flying in Alaska for a couple of years.
Wow.
And so he was new to EMS flying, and they sent him as their lead pilot when we finally got a contract, and that's how we met.
So he was with Keystone at the time. Yeah, yes. That's great. Yeah, he's quite an accomplished air medical transport field and pilot and leader. So that's fantastic. And do you have you said you have a daughter?
Yes, I have a daughter from my previous marriage, Lisa, and she's a certified psych counselor in Philadelphia at the JFK Center.
Oh,
and
wow.
She's the clinical coordinator for transgender population, and has quite a interesting career there.
Yeah, that's great. So do you guys have any pets or?
Oh, yeah. We do rescue dogs. So we lost our fantastic. 2 labs. Oh, yeah. We love dogs. We lost our 2 labs in about 2015, 16, while we were living in Colorado when Rick was working with Air Methods. And my secretary from South Carolina called one day and she said, "You're going to love this puppy. And I know you miss dogs." Well, her friend was driving behind someone in South Carolina and saw a little puppy be thrown out of the car.
Oh,
And she
jeez.
stopped and picked up this precious little dog
Oh,
and said, I'm taking him home. And then she called Gigi, my secretary, and she said, do you know anybody that would want it? And so that's how I got King, his name is.
yeah.
And then the vet, we had Gigi take him to our vet. And then she called me and she said, I have a dog. It's a beagle. Her name's Layla, and she was dropped off here. Somebody just dropped her off. And she's so lonely, and I can't. Would you take her?
Oh my
I
God.
know you had two dogs before, so that's how we got two dogs. Layla died last year, but we now have King, and he's precious, and yeah, he's definitely part of our family.
What kind of breed is it, or is it
Well,
mixed?
it's a Carolina dog, which I never heard of, but apparently the Native Americans had these dogs they raised
Oh,
on the border of South Carolina and Georgia. There's a whole history behind it.
oh,
And they all look a little bit different, but they're sort of medium-sized dogs, just very cute. He's black and white, and he's adorable. Great personality.
well, I thought you were kidding at first when you said Carolina.
No,
Yeah.
yeah,
Well,
it's really strange.
yeah. Um, you're doing a lot of I don't know how you have all the time to do all this stuff, but you're currently doing a lot of volunteer work. Talk about the work that you're doing and the agencies that you're doing it for.
Well, when I moved here a couple of years ago, this is a very wealthy island, a lot of wealthy
Yes.
people.
Yeah.
And so I was listening to a lecture by the school district president, and she talked about almost 40% of the children are on free or reduced fee lunches. And I couldn't believe it.
Wow.
And I took it to Will Hamilton, who owns Island Air. And I said, Will, can you believe that many children are on free or reduced lunches? And he was all upset about it. And we checked with several agencies in the city, and that was really true. So we got a group together, and we called them Nourish to Flourish. And we developed this thing called 36 Weekends. And they go around, and on Fridays, they take a brown bag of food for the weekend for the kids that needed free or reduced lunches. And it's done very sort of, not secretly, but it's not obvious that the kids will have a backpack with, names all over it. And it's sad. The stories we hear back are the families, the kids will say, well, my whole family enjoyed that. It's like, that's the food they had. It was, peanut butter sandwiches and tuna fish and that kind of stuff. So,
Yeah.
and then we also have something called Fresh Bucks, where they will get 20%, will meet halfway with what they buy on vegetables and fruits. And we raise money for this. And then, so for example, if they spend $10, we'll have another $10 they can use to spend for
Oh, that's great.
fruits or vegetables.
Yeah.
The other thing I do is I belong to Seroptimist International. And I don't know if you know what Seroptimist
I'm not
is.
that familiar. Mm-mm.
It's an organization of the United Nations, actually. And what it's for is to help women and children all over the world to promote education, better way of living, and that kind of thing. So Seroptimists of Friday Harbor has this, it's called Cancer Treatment Transportation Fund. And what I do is arrange cancer ferry tickets for the people that are going to the mainland for cancer treatment,
Yeah.
which can get very expensive because if they're going 5 times a week, that's almost $80 each trip. And, if you're already paying a lot for your treatment, this is an additional burden. So I really love this. This is right up my alley because I don't tell people when I talk to them that I'm a nurse. Because then I'll hear too much, but I do try to help them find the best way. We also have called the Eagles here, which is some of the older pilots who are retired who fly people for free in their airplanes back and forth.
Yeah.
So between us, we're able to help people out. It's really a great organization. We're having fun with Sarah.
That's fantastic. I know I've taken when I was out at Airlift Northwest. What's the distance that it takes on the ferry?
It
It's
takes,
about,
well, first you have to take the ferry to Anacortes, which is about an hour and 15,
yeah,
and then drive down to Seattle, if that's where you're going,
yeah,
or up to Bellingham, if that's where
yeah,
their
right.
treatment
I was
is.
just thinking of and that's why the air transport is so important
Oh, it's
out there.
very important.
Yeah.
Very important.
I remember working with the folks out there when I was there. So what do you all like to do for fun? What do you and Rick do for fun? I know you said something about hang gliding, and I'm going, oh my
Hang
gosh,
gliding.
you're still doing that?
We haven't done that for a couple of years.
Okay. Jeez.
Actually, we did hang gliding over in Switzerland, in Zurich.
Yeah. Wow.
Over that was fabulous. We like boating. In fact, we've sold all our boats in South Carolina, so we're looking now for a boat. That's kind of
Excellent.
boating and flying are kind of our two things that we do. And dogs. We love dogs.
So motor boat or sailboat or
No, but motor. Yeah.
motor? Yeah.
We're not sailboat.
Rick needs that engine there, I think.
Yeah. Fast engines. Yes.
So thanks so much. I mean, is there anything else that you'd like to talk about that we haven't mentioned that
No, I don't think so, Ed. I've known you for so many years, and I really thank you for this opportunity. Like I said, I've never done a podcast before.
Yeah.
So this is
Well, I had started these in 2009, and then I was sort of between jobs, and it was just I felt a fascinating way to because I love interviewing people. I love finding out about people. But I also initially I tried to make it a news program, and then I said, no, I'm not Brian Williams, and news people have to, talk in these little segments.
Yes.
And then it was already old. So, and people really liked the interviews. So then that's when I just did the interview portion. But thanks so much for taking the time out of your day. And thanks to Rick for arranging. I noticed people will see that if you're watching the video podcast, it says Rick, but it's really Eileen talking. I think it's Rick's computer at Island Air at the airport there. And thanks for arranging that because of to get the speed of the internet to be able to do video. So thank you so much.
Oh, you're very welcome, Ed. Thank you.
Thanks for listening to this episode of the Air Medical Today podcast. Please come back again and also subscribe to future shows by visiting the website at airmedtoday.com, iTunes, or on the Air Medical Today YouTube channel. Air Medical Today is also on Facebook, Twitter, LinkedIn, Pinterest, and Instagram, and you can find the links on the website. Remember, if you would like to be a sponsor or provide feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. A very special thanks to Stanley Reeves of Room Tunes, providing his song Track 5 for use as the theme song for the podcast. You can follow Stan on Facebook at facebook.com/stanley.reeves.39. Take care and have a happy 4th of July. And as always, fly and be safe.